Uh,
Are you okay? We're recording. Make sure.
so this is our AP virtual hands-on class, which is kind of an interesting experiment. I'm gonna be switching this hosting over to Luke here in just a few minutes, and then I'll wander over to the next department. It is 12/12/2020. And I also want to pull up my PowerPoint for today on screen share and let you see what else would have rolled out in topic discussion. So here we go. So can you all see that? AP
Yes.
Zoom? All right. So you should have gotten your codes for your ebook. Did everybody get the ebook codes and get them loaded up?
Yes.
Okay. Blake, you did too?
Okay, I couldn't figure out where to load mine. I clicked on the book and it wouldn't give me anything that says to load a code.
All right. So what you have to do is go to Canvas
All right.
and scroll down to where it says ebook,
I did that.
and then click there, and there should be a place where you can do that.
It says ebook on VitalSource.
Yep. Alyssa, you got yours to work, right?
Yeah. Underneath, I scrolled down and you'll find a place that says redeem codes. You should have that button somewhere on that page.
Oh, I don't. People, pages, files, symbol.
Ebook on VitalSource and the.
Got that.
Mhm.
So I click on that.
Yep.
Yep.
It says launch app.
Yep.
That's bookshelf, I think.
Yep. You're getting there. You're doing good, Alyssa.
I did. Yeah, she's got it. Yeah, bookshelf. But it only brings up the 2 books.
Okay, there should be a place on there where it says redeem a code.
Scroll down, maybe.
I did. And it says what's new and how to guide.
Hmm.
And I don't get anything else.
Hmm.
I don't know if you can see this, but this is
Uh-huh.
this is
Yeah.
all mine does right here.
That what yours did, Alyssa?
Well, I did mine on my laptop. So I don't know. Sometimes the more displays, but how about Lauren?
That's true.
I am right now in the bookshelf. I have to like sign in.
Yeah, she's quick.
I haven't tried it on my computer. I've only tried it on my phone.
Okay, all right.
So that might be the problem.
Blake, did you get it to load?
Yes, I did.
Did you do it on a computer or on a phone?
I did it on my laptop.
All right, all right. So
I'm not going to try going out right now because of me losing the picture last time.
Yeah.
I'll do it after we're done with this.
All right, so this is what the book looks like. And so one of the things I wanted to do today is make sure that you had access. This is only available electronically anymore. So
Been looking for it, used books.
you
Sometimes
might be able to get it
find
there.
That's
Yeah.
what I wanted to do too, was see if I could find something like that.
yeah, I really like the paper.
Yeah.
I do too.
So one of the things I wanted to highlight today briefly is application concepts. So we're learning methods, but when do you use them? And why do you use them? And so chapter 13 in the textbook addresses that specifically. And I've just pulled some pages of that up. for us to look at. And the first one here is the difference between an illness and an injury. An illness is either autoimmune, or there is some sort of pathogen. An injury is when we have had a trauma. There's and it can be micro injury that accumulates, or it can be an event like a car accident. And I'll post this PowerPoint on Canvas for you too. And then the idea of hurt and harm, which goes into the pain confusion between acute pain and chronic pain. Acute pain is supposed to indicate harm or potential for harm, and then it moves us away from that. But the nervous system can get kind of rewired a little bit, and so that productive acute pain can still send hurt or discomfort or distress signals, and that's what sort of becomes the chronic pain. And so the original injury or illness no longer exists, or in an autoimmune condition, or a persistent pathogen like herpes virus is there all the time, or Lyme, there's some residual pathogen. And we don't know if that's going to occur with COVID or not. But overall, the immune system deals with it. And then as an injury, again, the immune system deals with healing that tissue damage through the inflammatory response. And then we also create an immune reaction to deal with pathogens through the immune response. And we've heard a lot of that now in relationship to this COVID virus. And they're talking now about when you get the vaccine, you may experience these symptoms, and that's telling you the virus is working because it's launching an immune response. Another place where it gets confusing is cause of a condition versus the symptom. So talking about the virus, the cause is COVID-19 virus. The symptoms people get have to do with your own immune system trying to deal with that, and whether or not it is enough, just just right, or not enough, or too much. So a lot of the serious events that are occurring with the COVID outcomes is that the immune system is mounting a too aggressive response, and then people are becoming very ill and or dying from their own overdrive, their own immune system in overdrive. So it's doing all the good things, but it's doing way, way, way too much of that. So where massage fits into this continuum here is basically we, in general, substitute one set of signals for another. So we disrupt that pain cycle and reduce the stress response. And so the body can kind of progress through a normal healing phase without, there being detrimental effects with the whole thing. We don't often get to somebody when they're in the active healing phase. We're more likely to deal with people when they have chronic or leftover symptoms. And then that gets into that change in the nervous system I talked about, which is sensitization. So this graphic, I'm not going to go over it, but I want you to pay attention to it when you see it in the textbook. It talks about how we should respond. Our body should respond to a trauma like an ankle sprain or a pathogen like a bacteria or a virus or a fungus. So this then outlines that normal healing response and what we should do, whether it's an illness situation or it is an injury situation, trauma. In the acute phase, it's just pain management and sleep support. All the stuff you're learning, like working in the lats and all that, you don't do any of that. General focused massage, non-specific, and maybe shorter duration. You know, so you're just trying to help the person sleep. Sleep is essential in any healing process. So as it progresses, as the healing progresses, then we start to add to that, and we start to get a little bit of management of edema if it's an injury, and we manage compensation patterns. So for example, if somebody has been sleeping a lot, they're going to be stiff. They need to sleep, but they're going to be stiff. Or if somebody has an ankle sprain, they're going to walk funny for a while. So we don't deal with the ankle per se, but we deal with the compensation. And then a little later in that, then we can start to more specifically address the idea of supporting a remodeling process. And then, you know, whenever there has been an illness or an injury, there has to be a reset or a new, I hate the word new normal, but their body has to find a different way of functioning a little bit. We're never the same after something like that. We're always just a little bit different.
And as she said, regardless of it being a cast or something like that, it can disrupt sleep. I've had that before with clients where they have to get put in a boot or something, and it's just annoying. And even that. The other thing, the only other reason I'm interrupting, are you recording?
Yes.
Okay.
Yep.
That's all I had to say. But ultimately, what the key thing I wanted to throw at everybody is, and I've explained this for clients in the event that I'm working with a complex condition, something that maybe they are feeling cautious about, like they're scared of maybe having too much work and all that, or and wanting to know that the massage is going to help them progress in an effective way. And I will usually keep it more ambiguous to start, and I will say, you know, the worst case scenario is we use this to help you sleep better, and that helps your body recover and adapt much better, more quickly, just by facilitating the better sleep.
So here's some specifics from illness. And again, I've taken this right straight from the book. And, you know, we've talked about all of this already. So it'll be a reinforcement when you see it. And then recovery times. Now that varies on a person's health status, their adaptive capacity, their age, what other things might be going on. So these times are just average pretty much for a generally healthy person. So if somebody fractures a bone, you know, they're looking at, you know, at least a 2 to 3 month. This is just one of the little ones here. And, you know, and so we're not going to be massaging a broken bone area. We're going to be managing compensation and supporting normal healing for a long time. And say with an ankle sprain, we're still looking at minimum 3 to 6 weeks on something like that before we would start any aggressive type of rehabilitative focus. Now, movement, you know, bringing some general movement in, non-painful movement, sorts of things that you would find in a rehabilitation phase. That's important, but the guarding might stay there, you know, to try to keep that area still and it's acting like a cast. And if we try to take away some of that stiffness around a joint area injury, we kind of interfere with what's going on with stuff. So when we get down to here's Erica. When we get down to the pathogen kinds of things, typically, if everything, hi Erica, typically if everything is working well within the body and the person is generally healthy, you're looking at the body's ability to clear the pathogen. You've heard that term, in about 14 days. If they're not really that healthy, or there's something that's interfering with the immune system response, like diabetes. Diabetes interferes with the immune response. Then they may never truly clear. And they might have a relapse, or they might continue to have a persistent or aggressive immune response. And then that can progress into something called inflammatory disease. And then that's the basis for chronic pain, fatigue, that sort of stuff. So people ask all the time, when am I going to be back to normal? And I put a Facebook post up on that yesterday, I think, about what's normal, and maybe they're asking for familiar. When am I going to be back to when I felt like I did before? And that's frustrating, because probably not going to feel just like you did before. And if you're comparing the way you function and feel after an event to the way you felt before, you're always people have a tendency to think that the way they feel now is bad and the way they felt before is good. And so there's a psychological mind-body interface that occurs where they keep trying to get to where they were before instead of maximizing where they are. And massage can help them do that. Now, we have not done any releases or anything here yet. This is just an approach on how we are working with things. So again, this chart is in your book, Slow Down When You See It, but it tells you what happens when we start to get a little anxious about stuff and we get into breathing shifts. And many of the mechanisms of massage and many of the interventions we do in this chronic everything syndrome really are about how we are helping somebody breathe better. They all kick into the breathing. So you'll want to, well, this won't be the first time we touch on this whole breathing thing. And then this goes through and talks about the different sensations and changes people might have. So when they're breathing in excess of demand, you're breathing like you're running for your life, but you're not. So these are all normal responses. And you can come back to this. This is in the textbook. You can come back to this and do an assessment on yourself of which of these, do I have? Do I have lots of them? Here's more.
I mean, I'm a little disturbed.
Holy
cow.
I can look back on this and I can go, okay, there isn't a pathology here, but there is a strain on the system. This is a normal thing happening at the wrong time. A normal thing happening at the wrong time. So you can't get a diagnosis on it.
Right.
So people try to make sense of this. So slow down and pay attention to this in the textbook, this breathing pattern disorder, and notice how many of these things people might say to you when you're giving them a massage. You know, I feel like I can't get a breath. It's stiff along my back, right under my ribs. It feels like I can feel my heart beating. I can go on with this. So this slide is then talking about all the different things that can happen that massage can help with. That we always continue to go back to, if I can't do anything, I can focus on normalizing breathing and anything that needs to be done to normalize breathing. Because people are always asking, what do I do? What do I do about this? What do I do about that? What do I do about the other? Target breathing. And again, this is taking you through kind of the sequence of stuff that happens. If a person is breathing in excess of demand, over time, those muscles are going to get stressed and strained. They're little. They're not supposed to do that over and over and over. And so then you start to get maybe that trigger point phenomenon, or the posture will shift and change. Things start to get stiff. We tend to roll in on ourselves, which allows for some relief in these upper chest things, but then that leads to low back pain. So it's a pretty, when we're continuing to look at what can we do, what can we do, what can we do, this is where we continue to come back. And if there was a theme in advanced practitioner about what to do and what to look for, this is a reliable intervention point. And it's typically not going to make anything worse, and it has the potential for helping the person do better. So when we actually get into more technique on this, these are assessments that you will use. And again, they're pretty self-explanatory, and they're in the textbook. They come down through this. And then here's the muscles that we tend to target. These are the functional areas that are, and the associated connective tissue and joints. Scalene, sternocleidomastoid, serratus anterior. We started to work on these in class. So these become, depending on how a person is given, symptomology. And I don't know what we are going to be able to do when we get over there for the hand, as we're trying to demo this, what you can see and what you can't. We're in a real experiment thing here. But how can we started to work on some of these. It's not that you already know how to work on the calves, the whole upper back, without even a specific method at all. It's rhomboids, upper traps, pec major and minor, and latissimus. You already know how to do that. And you get serratus posterior and superior along with that. So it isn't like you don't know how to do most of this already. It's more of a mindset and more of a focus. Now, this link right here is up on your Canvas, and it is a research webinar that the Massage Therapy Foundation put on. And it's particular to pain management, but it talks about a lot of the stuff that we are kind of looking at here today. And I encourage you to look at that. And it will reinforce some concepts around this and hear it from another voice. The other thing that happened, and then I'm going to switch this over to Luke. I don't know where Luke went. Do you remember in class when we had you build a joint model?
Mm-hmm.
Remember that? Well, we did that virtual with the current class that I've got in, and there's 11 of them in there. So we were able to do pretty much the whole body. Those are up on the YouTube channel. And there's part 1 and part 2. And if you're any of you are still in a situation where you're studying for the MBLEX, I see Lauren up there. I think you get a kick out of watching those. I think it would be a good review process for you. So those are up on the YouTube channel. I don't know if I put the links up on your Canvas or not. So Luke, where's your little self at? There he is. So our focus, an area where we can reliably help somebody, sort of kind of regardless of what's going on with them, is to support sleep, substitute a more pleasurable set of signals. Now, those aren't always, sometimes they don't feel good, but they feel right. Substitute one set of signals for another, and then make sure the person can breathe. And that they're not stuck in this upper chest breathing. Those are the three areas that we can reliably intervene regardless of what's going on. And then we also have to screen for contraindications and make sure we're not pushing in an area that we shouldn't. So I'm going to make Luke the host. And let's see how I do that. No, it's not the chat. Participants.
When you come over here, there's a full herd of dogs.
A herd of dogs.
There's another one that we're giving to Sarah's sister. So we have 2 black labs and 2 German shepherds.
Wow.
Luke, getting you here.
Another leader dog. This one will get
Oh
you
my.
to a client. So we're taking over raising the shepherd until like July-ish. And then the other one is what they call career change, but that means, it's a euphemism for flunking.
Okay, Luke, you should be the co-host here.
I didn't see anything prompt up.
And really, you don't have to share your screen or anything.
Yeah, I should be good.
I've got to change the view here to speaker view so that,
That's for the recording. You know that doesn't go to everybody, right?
is that only for recording?
No, that's just everybody would have to do they can pick their view,
Okay,
but whoever's doing the recording, so if I'm recording now or you are, then we
yeah,
speaker view. That's what we want.
yep, I've got that on there.
And then as much as possible, other people with good questions and stuff, if you don't have too much ambient noise, you can always mute yourself, all that. But that way, when we speak, the picture will get big. Then when we record the video and you can go back and look at it, it'll be just us rather than like it just be the gallery of everybody. Everybody.
So I am going to mute me so that you don't hear the birds.
This isn't the prettiest of the models, but one of the students back in the day made this guy all
Wow.
beaten up, but it's got most of the muscles represented here. So for this visual learning via Zoom, I've used this to be able to just quickly represent and show rather than bringing up pictures and stuff on the. But to reinforce some of the stuff that she's talking about, one of the taglines that I remember her and even Joanne speaking about when I was getting through my training is, I just assume everybody breathes wrong. It's not going to hurt anybody to continue to breathe well and or to breathe a little bit better. There's always going to be a system-wide benefit and effect by targeting upper chest breathing accessory muscles and helping a person belly breathe / use their diaphragm better. And by simply inhibiting the tone of all these upper chest accessory breathing muscles, that challenges the diaphragm to fire more effectively. Give me 1 second, please. They want to, they'll try to jump up on you. I'll let you sneak in there.
Love it. Look at, I reappeared.
It's a magic trick. We live next door to each other.
Trick.
So I'm gonna raise this up while I'm talking. I honestly, I tell you guys, it doesn't matter for me. You're a whining shepherd, but that's all right. I'll start because the first session with clients, there's a lot of assessment. So I don't usually challenge them and throw in a lot of interventions early on. It's going to be, oh yeah. So, but I can usually assume that targeting breathing is going to be a component in some way, no matter what, right? So that doesn't matter if it's a pain-related component or even in the sports world. I can always assume that somebody's challenging their system, like in building up strength and endurance. They are actually using this breathing reflex when they shift into that high gear, that sympathetic arousal, to do the marathon, to play the game or do practice. That's healthy, that's normal. But then they need to be able to, our system is always good about basically everything turning on and maybe doing a little bit too much. What are you looking at?
I'm looking at
Oh.
that.
Just see her neck craning on the side here. But we can usually assume the body does a little bit too much in all of this. Usually in the spectrum of sympathetic arousal or too much muscle tone, we don't see a lot of somebody down regulating too often. That can happen if somebody's mobility, their mobility is inhibited, maybe there's a paralysis or something like that. But I usually can assume that with guarding patterns, breathing dysfunction stuff, the body just goes one clip too far and doesn't get back to normal. So it doesn't return certain muscle structures to their normal resting length. It'll kind of keep you guard, like a shoulder injury, it'll keep you guarded in this kind of sling state.
Yeah.
So it's almost like a better safe than sorry scenario as far as the body's concerned. It doesn't care that you're uncomfortable. It knows for sure that that shoulder joint is protected if it keeps you like this. So we have to kind of convince the regional muscles to return to normal resting length so they can be more comfortable. But embedded in all of this is always going to be screwed up breathing. And that can be that it translates, it can be that the pain mess with their sleep, which then is going to create a system level of stress, emotional and physical stress. And even that's a part of the breathing. So what I said earlier about the sleep component, we can really do a lot. I have used this as kind of one of my base level tactics, is to start with the idea of really reinforcing going after the accessory breathing stuff. And then from there, sprinkling in some interventions, but with the first session in particular, I'm assessing so much, I don't go for the immediate like deep releases every time. But I can always confidently go after the breathing muscles and know that's at least gonna give them some sense of relief. Maybe they sleep better. And by the time I get to the next session, I have my paperwork, I've assessed, and now I can get more and more targeted. And then I'm going after things like psoas, quadratus lumborum, subscapularis, which all of that, especially like that one, the stuff up here and anything related to the shoulder blade, you can assume is going to be involved with weird breathing, postural stuff. So anyway, that's my 2 cents.
Well, and in the class, they put,
Oh.
in the class that we were able to have hands-on, are you leaving me?
No, I'm getting my coffee. This is just like being in the classroom.
You have to love us. Well, I'm in this little room with a herd of dogs.
I have a baby gate keeping them out.
So when we were in class, the day we were able to get into class, we worked on the anterior chest. We did pec major, pec minor, and then we brought that around and got into the lats. We did that, and then we got into this upper trap area. Those were ones that you can relate directly to breathing. Now, Linda, you kept saying over and over that you know somebody that really needed that. Did you have a chance to practice this out with them at all?
No, I haven't.
Okay. All right. So I want to reinforce again and again and again that you already know how to do most of this. So generally, we are, whoops, we lost Erica.
Yeah, she'll come back. No, she's just.
No, you got to admit her.
Oh, whoops. She was there.
There she goes. She's not got the greatest
I'll
connection.
keep that in mind.
Yeah.
Okay.
We talked about that our main intervention is inhibitory pressure, sometimes called a static hold, compressive or compression, plus movement, if movement is feasible at the jointed area, and most of the time it is. Erica, we'll just keep admitting you if you keep dropping off.
Yeah, sorry. We keep zooming on days where North Branch internet is real shifty.
Question I have, you and I have talked about this, but it's a good conversation for them to hear. What is the opinion on using the actual breathing as the movement?
That's-
Compression plus.
Yes.
I sometimes will try to push a person to exaggerate the breath. The key thing I usually have to tell a person is make sure they really exhale, air all the way out.
Yep.
Air all the way in, and air all the way out. So a little bit of an exaggeration, but you can use the breathing as the movement / the muscle energy technique. I've gone so far as compress on the area. This is more specific to like that serratus posterior superior, which is directly underneath the rhomboids. If you ever try to figure out where a sneaky breathing muscle thing is, it's underneath the rhomboids. It doesn't attach onto the scapula, it attaches directly on the ribs, and it's all about inspiration. But anyway, with those, the more aggressive technique has been to compress it and have a person cough. That's a big contract, relax, to have a person cough while you maintain the compression. But you can even go so far, there's a middle ground. There's the nicest, the least invasive one, I won't say nice, but the least invasive one is compression with breathing. I then do a middle, then the more aggressive one is the coughing, but there's the middle ground one that I'll use where I'll have them inhale, hold their breath for a few seconds, and then exhale. The holding of the breath acts as an extension of the contract, like how we'll tell you to have them hold the contraction for at least a few seconds and then go the other way. So using breathing, everything from just regular breathing to more exaggerated breathing to a little bit of a holding of the breath to even a cough can be a way that we can get more specific and more targeted with this.
Now, muscle energy technique is a specific type of an approach, but it can be generalized. So technically, muscle energy technique means that you have done an assessment and you have identified, most of the time, you have identified a joint motion, a range of motion that is short. And then you're going to use a series of controlled, very controlled contractions against resistance to kind of reset the nervous system. So we've taught that to you as contract, relax, antagonist, contract, stretch. So you've learned how to do that, mock that up. So we're going to see Luke's elbow. I'm going to run it through its range of motion. And let's say it stops right there. I can't get it into its full extension. So my target is here. I want that to let go. At the same time, I want the antagonist to actively engage. So the easiest way to do that is to have the muscle that is short contract. You don't have to push hard just for a little bit against my resistance, relax, go to the opposite side of it, antagonist contract, and let them, this would be active resisted movement, let them
Wow.
stretch it out on their own.
Push
Okay.
through you. I usually have to say push through me. You're letting them win, but we don't want it to be where they're recruiting. That's the thing that I usually have to tell people, like slow, controlled, just push through me. But you don't want a person when they do this just suddenly go "Ah," and use their whole body. You want them to target that specific antagonist. So sometimes you just have to coach a client. Like she said, you shorten what's too short and then have them relax, then have them activate what's too long to try to get that balance back. So you want the too long thing to get short and you want the too short thing to get long. And it's always this agonist antagonist relationship for every joint you can think of. With the hinge joints, it's an easier example, right? This stuff on this side does this stuff on this side does that. So if I see a limitation at the elbow joint, I know it's one side or the other side. Other areas of the body, shoulders and hips, a bit more complicated.
We used to teach this back in the day, much more complex. But over time, you've got to find practicality in how you approach things. And it's come down to the easiest way to teach this first, and then to incorporate it into the session is know what area it is that you're trying to restore a normal resting length to. And even if you do it backwards, it doesn't matter as long as you are focusing on what was short and that you want it longer.
I sometimes treat it where if I can just hit the reset button on both sides. So that is a good example of just a practicality standpoint. If you don't know, you do contract, relax, antagonist, contract to both sides. When they're laying supine, I can do that for biceps. I can apply inhibitory pressure here, have them bend it one way, bend it the other way. Through resistance would be better because that exaggerates the action of the muscle. And then when they're laying prone, I do the same thing to the triceps. I compress here, have them bend it one way, bend it the other way. If I do that to both sides, the body is conditioned to self-regulate. It should usually, it's like the whole thing, like you bump your shoulder and after a few days, it does get better. Usually the body, we just sometimes need to nudge it. So by doing more of a generalized approach like this, where worst case scenario, reset both sides and make sure they can breathe better so they sleep better and hopefully the mess gets cleaned up.
So then again, in practical application with this, you have seen Luke and I do inhibitory pressure. Usually we are putting the pressure into the belly of what we think is the tissue that's primarily involved and why it's short or symptomatic, and then roll it in a circle. Roll the area in a circle, which in essence is that whole contract, relax, antagonist, contract. In addition, you get a little friction under there. The other thing to do with that, because your eyes tell your body where you're going, so you get some facilitation in the movement, is to move your eyes in a big circle, or look at where I'm pressing, then look totally away. Look at where I'm pressing, then look totally away. That's contract, relax, antagonist, contract. While then added into it, we've got some inhibitory pressure. So we're combining thought process here. Your job, when we do these releases that we're calling them, for lack of a better name, is to instruct the person in the movement, occasionally offering something for them to push or pull against, and applying another sensory signal into the area that's sending the signals that are discomfortable. You like that? I like that. And potentially mechanically affecting spindle cell mechanisms or other proprioceptive signaling in the area.
And that's kind of the, in terms of the scientific basis behind the muscle energy technique idea, it's interfacing with the nervous system. But the nervous system is what sends the signals to these muscles to contract and relax, etc. So if we don't have them do the act of movement, you're not going to get as much of an effect as quickly, usually. And movement with resistance exaggerates that effect further. The muscle recruits and uses more of the muscle fibers when it's pushing through resistance than if it is just through gravity. So that's the reasoning behind it. And then beyond that, with the movement, you will always get some level of friction. If you combine that with inhibitory pressure, you're going to get that friction of the deep fascia between muscle layers. So it's one of those like good, just in general, compression plus movement, if possible, through resistance and through some range of motion is just going to get a lot done. It interfaces with the nervous system and resetting the muscle tone, and it creates the friction of the fascial layers between the layers. Which one are you looking for?
The skeleton, but you might have took that back to the classroom.
The full skeleton? I don't know
No.
if we had a full skeleton.
No, the little one. The little one. This will
Yeah.
work.
You just chit chat with it.
Okay, so now we come down to the mechanics of this whole thing.
I have a tiny skeleton. Do you want?
No, this will work.
Okay.
Which is the muscles that we are tending to target with these releases are underneath other muscles. And so they're a little hard to get to, and they may lie adjacent to nerve plexus or blood vessels, lymphatics, and so they're sensitive to touch in general. You've got to be pinpointed with your compression, and you want to do the compression in a way that it doesn't hurt you to do this. So we try to use our forearm as much as we can. Next thing is a fist. And if we're going to use fingers, we want to use a braced hand, and you don't want to use your thumb. So depending on how we get into an area. So Luke's wandering around. So you're back. So, and you can feel these on yourself. And so do that. We're going to feel around the base of the skull right here, right where there's a little knob in through there, right at your earlobe level.
Yeah, I usually tell you start right behind your ear. You'll feel a big bony protuberance right there. That mastoid process. That's where sternocleidomastoid kicks on. So if you watch, I have to move just right. I can get that guy to, let's see if I can, there. It's harder to see. If you move just right, you should be able to feel that this big sternocleidomastoid kicks on and it catches right there on that bony knot. Then you can trace following the line of the skull. Just let that, I usually have to go up a little bit, but you can trace that line all the way around.
So these ones that we're going to look at here in this, we were thinking that our first challenge to teach like this, we would take a look at the upper body in through here. And these are the big into the accessory breathing idea, headache, neck and shoulder type stuff. And so it made sense, as we're learning how to do this too, to kind of target those areas. So if we are thinking, get a little closer to the camera. Okay. There we go. That we're going to pay attention to a line that runs right around, right where the knee, the knee.
Where the head meets the neck.
Yeah, right here. And we start looking at that from superficial to deep. We've got sternocleidomastoid that comes up and takes a very large attachment right here. And it's safer to get it there, to work it there for the compression than down here, because there's the jugular vein, and the carotids are here, and nerve plexuses are here. So if we can try to get a person's relief here, then we don't have to do the more aggressive pinch the muscle directly. Then trapezius, upper trapezius comes up and hitches just above that in this whole area in through here. So one of the areas we worked on was compression here at the shoulder. But this then, the other end of that is up here. So if we compress here, then I can have him roll his head, and that's getting my contract, relax, antagonist, contract, with my inhibitory pressure here with a pinch and or a compression. So the movement of the sternocleidomastoid is, it's that, but it's more of a tuck your chin. So get that.
When they fire together, but if one fires individually, it does a little rotation. It's
Yep.
kind of a weird, like chin in and twist.
So it's about really tucking that chin. So when you tuck that chin, okay, and then this is when it shortens, and this is when it lengthens.
You can really get a good motion there.
I bet you that looks really good on camera. Okay, now underneath these more surface tissues now that are easy, you can see them on a muscle chart, we have some strat-based muscles.
As we do this, try to make sure, because I don't know if it's recording off my computer or yours. I should be doing the speaker view. Okay, let me say a word. It's not going to me. Just stuck.
Hello.
No, it's,
Hello.
there we go. Okay, there we go. Now I think we're,
Hey.
Okay, let me, it won't show us because we never get up on speaker view.
we never show us. Okay,
All
got
right.
it. All right.
All right, so underneath these strat muscles,
You want the gallery back? for
yeah,
you? Okay.
yeah.
Sorry, everybody.
There we go. We've got some underneath this upper trapezius thingy and the sternocleidomastoid thingy. There's strips, splenius capitis, splenius cervicis. They're part of the whole strip that runs down the spine.
I just assume they're part of the erector spinae. There's a cervical part of the erector spinae, kind of interface with those guys. That's not quite true, but they're right by it. The actions are similar.
But they're underneath. So when I'm targeting in through here, if I am thinking just a little deeper and a little closer to the spine, I am gonna get that. And then the other group in here that shows up is the suboccipital group. That's really deep. That is, hold that right there. Right underneath, almost right where the foramen magnum is. It's way underneath there, and they're positional receptors and their little tiny movement thingies.
But if you guys always reflect on it, I've shown you before. But if you actually look at just the skeleton view of things, there's a huge ridge here. The occipital bone projects out a lot from where the cervical vertebrae meet, right? And that's just filled in all with muscle. So it's important for us to remember, just particularly right at the base of the skull, how many layers of muscle there are. So those suboccipitals deep underneath everything, and then the stacking and layering. You have from everything from the tiny muscles around the vertebrae, multifidi and rotators, to then the splenius, cervicis, and capitis, to the erector spinae, to levator scap, to upper trapezius. It's just, and they're small, maybe kind of thin, but there's a lot there. And that also means it tends to be pretty sensitive to apply a fair amount of compression here. And that's where the forearm is so essential. It broadens our basic compression so we can apply enough force to get to at least get enough strain and stress into the tissue to be affecting those suboccipitals. And this is one of those areas where, regardless of who it is, if it would feel intense or uncomfortable, even if there isn't a problem there. There's so many layers of muscle, they're so nerve rich that
Yes, there's a lot of nerve. And so, you know, if where we're pressing isn't recreating a familiar symptom for somebody, then we don't want to just stay there, because, you know, we're always chasing the familiar sensation. And then while we're in this area, behind sternocleidomastoid are the scalenes. Now, they don't attach onto the skull per se. They go from the cervical vertebrae to the ribs. But because they're on the ribs, they're supposed to hold our head this way, you know, so that we're not flopping like this, or, you know, that's what they do. But because they attach on the ribs, and anything that can attach on the ribs puts us in a position where it can be an accessory breathing muscle, and accessory breathing muscles will shorten. The issue here is there's not a lot of space in here. There's a lot of stuff that's trying to get up into the skull, up into the brain, and out of it. These are called outlets. And we're trying to deal with the cervical and thoracic area right here. So if it's crowded, those things get pinched, they get pressed, and that can cause symptoms. So the scalene symptomology is,
let me close again.
yeah, so they're kind of right in this area right here is something up that goes around the ear a little bit.
She's saying the referred pain
Yeah.
pattern.
Goes into the front of the chest, can come into the top of the arm, feel like bursitis, then turn around, back up a little bit, or goes right into that spot between that people say they have under their shoulder blade. These can be all addressed really well in the sideline position with somebody. And you can do it as just a general part of the massage without being aggressive, just as a general cleanup on stuff. And that if we get into a situation where the person is saying, oh, that's it, thank you. My nose was dripping. We get into a situation where somebody says, ooh, that's my headache, or ooh, that's that spot behind my shoulder blades. So positioning and putting some compression and a little bit of movement in this is a general cleanup, and then becoming more focused if we get a familiar sensation. So we're also using these positions for assessment. If we decide to intervene at that point, then we get just a little bit more focused. We certainly add more deliberate movement to that. And we slow it down and may stay there just a tad longer. Not too long. Better to swing around, do something else, and come back. So, all right, so let's look at what this looks like on the massage table.
To reinforce real quick that I want to just pull that together. You can assume that all of these muscles are involved with an upper chest breathing or kind of construct. Even sternocleidomastoid attaches onto the clavicles here, so it can actually elevate the clavicle up toward the head for chest breathing. The scalenes upper traps, all that kind of stuff that can be involved with an upper chest breathing stress related dynamic. But also these structures have a lot of, if there's a trigger point phenomenon, you'll see that a lot here. Tension headache, migraine related headaches. Even if the migraine is not a true migraine, it does still change the nature of how you hold your head, that headache response and pain response. So as well as classic, if they have a headache related issue, these are where you go. And it can be some of those strange referred pain patterns like she was talking about. Scalenes are just a very common fiend when it comes to this. So anyway.
So sideline position is your best position for these.
Where do you want? Face that way?
Head that way, head here.
Yes, but my face that way?
Yes,
Face
face
okay.
And we'll turn you over. Okay, I'm looking, I think we need to move the screen.
Yeah, we do need to bring the screen down a little bit. We're figuring this out, guys. Fun little studio here. You can see her good. You can see the
I really
table
want to
good.
see my arm.
Yeah, you got it.
That was me.
Yeah, are you okay?
Yeah.
Okay.
I was making a cut your head off.
Yes, no. Lamb's really loud.
Oh. Okay, now, if you can put the area on, switch down this way a little bit, move down, Fritz. If you can put the area on a little bit of stretch to start with,
By just taking the pillow out.
and somebody can lay like that comfortably, that's fine. If not, okay. So I'm going to take the pillow out so that you aren't confused, and able to see what's going on. Key when you're working these areas is that you want the nose to always be facing the table. You want that nose down. And what that does is protects all of the vessels in the anterior triangle of the neck. And if we work from the top down, it's pretty easy to just include some of this in the general massage. Now, in order for the camera to see this really good, my body mechanics are going to have to be compromised just a little bit. I'm going to have to reach a little bit. So pay attention to where my forearm is going. Focus there, and also here on my hand a little bit. Those will be the two areas that I'm using.
Do you think you're happy with that, or do you want it closer?
No, I think we can get it. We'll try it. All right, and you guys feel these areas as I am accessing them. So find that bony ridge, that area that starts just below your ear and comes right straight across. That's the first area we're going to massage. That's the upper trapezius coming into that. And because that also works some on the shoulder, I can have, because I'm going to be compressing down on that, I can have him move his shoulder and or exaggerate the breathing a little bit because it becomes part of that. So not the bony side of your arm, more of the flat, so your palm is down and you're just leaning into that. As an alternative, you can use this part of your hand and lean into it. You just work yourself down behind the ear, and you're going to end up where the sternocleidomastoid is at. Now, the angle of your approach changes a little bit. I'm more trying to cut his head off, in the transverse plane right through here. So I'm like trying to take the top of his head off when I'm at upper trapezius. But as I move down to get to the sternocleidomastoid attachment, I'm heading up more towards the top of his head. And I'll fit right underneath a little ledge in there. And I can use again, either my hand or the soft part of my forearm, and I'm gonna be bumping. I'm about maybe an inch below where I was for the upper trapezius. I'm gonna be bumping right into that mastoid process right there. And then my movement is difficult because I got everything held down, right? So this is where I would either bring in the potential for the breathing or the eye movement. This is where I would really use the eye movement here. Roll your eyes in a big circle.
I'm just illustrating. You tell them go one way, go the other way.
And we can try that head tuck and chin jut.
If you can get them to understand it. But they can find the movement, usually it feels right. They go, oh, yeah, that does make that, exaggerates the sensation. They can feel the muscle contracting and pushing up against the compression. So usually just feels correct for them. They just play with head movements, even though you're smushing their head a little bit into the table by having them do, I have to tell them really small movements if they're going to do any of this. But it does usually feel, it's intense, but it feels correct. It feels like it's doing something valuable.
So this line, then here, and then we're going to go right under the skull edge. Tip the head just to fit. Always make sure the nose is down. And I'm going to come right underneath, little bit sharper part of my forearm, more towards the back, not towards the front. Come down and then angle up. Come straight down and then angle up. That's your suboccipitals. Slowly, slowly sink. And then you'll ask, does that feel familiar? If it doesn't, then just kind of work your way out of it. That was your assessment. If it is familiar, just increase it just a little bit, add movement. This would be the eyes and the neck maybe.
And sometimes you have to chase the spot. It can be where my forearm is positioned. I might have to ask them, and I'm maybe moving only a few centimeters in either direction, kind of shifting where my forearm is applied and kind of just shifting my angle one way, another way, maybe up and down, maybe more toward the posterior side of their body, more to the back of the skull, toward versus a little bit more on an angle with it. And just searching for what feels familiar. Tell me when it feels like I'm really on the spot. And everybody knows what you mean by that, but you'd be amazed if we're talking the tiniest little shift from being near it to right on.
So while we're in this general area right in through here, we can just change direction and our angling. So this is a 90-degree straight down. This is at more of a 45. The suboccipitals is a 90 straight down. Always feeling the edge of the skull. And then the scalenes are 45 again. Now, because of the camera, he's more in the middle of the table. But if his head was positioned typically, that's when I would come in with my forearm.
They can see the edge of the table.
Can they see the edge of the table?
Yes.
Yeah.
The whole table's in the shot.
Oh, okay. All right. So here I am. You know, I've gotten here. I've gotten here. I've gotten here. I'm going to come to the top of the head, and now I'm going to come in here. And right where the neck curves into the shoulder, right there. And then a little tip forward, I'm exaggerating it, little tip back, you got your anterior medial and your posterior scaling. So this is a breather. So this is one where I would say, okay, does that feel familiar at all?
Yes.
And what about that one?
More. That feels like
And then about that?
the second one.
That one? Okay. So I'm going to come in, down towards his feet, just a teeny little bit. And I'm going to say, nice big breath. Blow it all out.
The scalenes are accessory inhalation muscles. They help you bring the air in and chest up. So doing the expiration of the air out is like the antagonist contract. My breath in is the contract, relax, breathe out, antagonist contract.
Now, the other option I can bring into this is to keep your head still, but move your eyes and look at the spot, then look at the table. When he looks at the table, it's the letting go, so that would go with the expiration. When he looks at the spot, that would be the inhale. Now that can get pretty confusing, can it? So I don't get too concerned about that. I'm more concerned about big breath in. And then now add to look at the spot and look away.
Now, depending on the person and the sensitivity of the trigger point, I can tell you from my experience, there is, even if I'm not doing any movement, as the client, when she has compression on that spot, I kind of have that trigger point sensation. If I look at it, it exaggerates the sensation, makes it feel more. And if I look away, I feel it less. It's subtle, and some people aren't as body sensitive as others, but for some people, and I'm one of them, it can be pretty profound. Just looking at it exaggerates it, and looking away from it takes it away. And even that does really work, kind of like a contract, relax, antagonist contract.
So while we're in this area, even though they're not set up in our specific quote, quote, releases, whatever that is, there are structures that it's just easy to access in here that can be headache producers, and they're connected with chewing. So if somebody thinks they have some TMJ stuff or whatever, so right here on the side of your face, you got your masseter, and then right above your ear, you put the heel of your hand right above your ear and come over, that's your temporalis. And so while they're here, again, I can use that flat of my hand and I can work that temporalis. And if I want to add a movement to it, I would have them clench your jaw and then open. And again, that tightens it, that lets it go. And again. And then always moving that scalp around, and then down here on the masseter. Mostly right where the ear canal comes in.
I usually know I'm doing a good job if I see the ear changing shape. I, as a massage therapist, I look right at the ear, and I should see it almost opening and closing as I move these tissues around it. I know I'm getting a good pull on the tissue just by using that as a reference. That was weird. She will actually grab people's ears and move them around.
Yes, I do.
I'm not brave enough, but it feels really good. I just, with the sports guys, there's kind of a perceived dynamic where, like, imagine in the training room, I'm just grabbing their ears.
But it pulls all that.
It feels great. You would be surprised. People with headache-related TMJ stuff, the ear itself interfaces with all this attachment, all the, like the deep fascia of the jaw, the deep fascia of the skull, the deep fascia of the neck. So be aware of that for your own self-care. And oddly enough, it's a goofy thing to show your clients, but just to show them to tug on their earlobes to help with their headache.
Well, if you can do that yourself right now, tug on your earlobe, take it out to bind. and open and close your mouth, you'll feel it tug. Also, open and close your eyes, you'll feel it tug. So a lot of times I do have that ear kind of in here while I'm doing that, and doing a little bit of a tension force between the two to get more into the connective tissue stuff. Now, we already did pat, roll on your back.
To my back.
Yeah, we already did pectoralis major, pectoralis minor, and latissimus. You remember those? So you've got a nice sequence in here that can work towards this upper part of the body in the as we're dealing with a breathing focus. A couple of other things while we're here that's just real easy to do is chest compressions, which we've already, springing the ribs, we've already taught you how to do that.
But the scalenes attach on the first two ribs. So if you depress the rib cage, holding it down, if you push the rib cage from that direction, if you're toward their, you're standing at their head and you're pushing the rib cage down toward their lower body, toward their feet, you're basically putting the ribs in a exhalation position. I visualize it like an umbrella. I'm trying to, the umbrella is stuck open and I'm trying to close it. I'm always trying to get that bellows or umbrella to go back down. So if we hold the ribs here, I'm actually lengthening the scalenes. I'm lengthening the attachment of even sternocleidomastoid, because that compression is going to even pull a little bit of the clavicles down in a way.
If you cup on both hands here, but if you couple that, where you're, now we're working more at the sternal attachment of the sternocleidomastoid, and then have them tuck their chin, you can really feel.
I mean, it's very profound, that deep fascial stretch. And I do this for myself, by the way. So if you, this one feels pretty good. If you guys reach up, find that sternal notch right here, you'll find that SC joint, sternoclavicular joint, go just below it, get a good compression on that and pull it down where you feel a little bit of that kind of skin stretch. And then play with the neck movements. It can be very profound in getting that kind of deep fascia tug. And I use this for my self-care a lot. But now imagine you as, when the massage therapist applies that compression, it's a broader compression, has a little bit more force to it. It's even more profound then. So, but it's just, this whole, it doesn't get addressed too often. And worst case scenario, I as a male therapist have to always be cautious. But you can do a pretty good job with a thinner pillow over top of this so that I have a barrier. It still is going to get a compression and tug on the tissue. So anyway.
All right. So
why not lie down now?
yeah. So for video's sake, we've been at this an hour and a half. And so here's what I want to ask you guys. One, what was your sense of being able to see what we were doing? Could you follow?
Yes.
I mean, I can, but I would like to see the jaw more.
See more of the jaw?
You want it zoomed in?
Like the TMJ work.
Want to see the work, or
And I'd like to see positioning better, I guess.
yes? Can you see it well enough from this angle, or do we need the camera closer? Do you think?
I think I can show it if you just bring your face up here.
No, I can position this and just bring it. I have this on a music stand, so it's going to look a little clumsy as we do this, but right here. And then just don't bump it.
Okay.
And if I bring this down,
Perfect.
we should be able to be right. So this is zoomed in. So
All right.
You're gonna have a good close up of my face. All right, I can see myself.
Oh, yeah.
All right, so again, just as a precaution,
No,
always
no,
have the,
starting the massage, it's pretty easy to do this because you just do some techniques to kind of just roll them away from you. I always make sure they breathe because I'll stare at them. I can see their face pretty much. And hopefully they're drooling and relaxing and everything's good. But I just check in. I'll say, like, I'll kind of give a smush here and go, you can still breathe good. I'll make a stupid joke about it or something. But that it feels good to get that work in the back of the head, but then that naturally is going to push them in such that it puts them in a safe position for you.
all right, so while we're closer here, this is the area where I'm coming in for the upper trapezius. See how I'm lined right up with the ear? Then I'm going to come down and my angle is going to be up to get the sternocleidomastoid. This is the alternate position. Then I'm going to cut his head off to get the suboccipitals up against the skull. And then I would come around to get into the scalenes, a little bit forward for anterior, medial, posterior. While I am here now, this is a very complex area. There are actually little muscles all around the ear. They're vestibular? No, anyway, we don't use them very much anymore, but Luke can move his ears. Can you move your ear? You'd be surprised how those may refer pain into an earache or even into the jaw. So now I'm in a position. So here is a hill on the skull, and coming in this way is a hill on the skull. I can just start for the whole TMJ. See how I'm behind the ear here? If I am focusing TMJ, I want to feel what's happening in there. So I would get a position and then I would say, okay, clench your teeth for me and then open. And sure enough, I feel something move under my hand when he opens. I would narrow in on that just a little bit and then I would have him produce the movement. Close your mouth, a little clench, open up. And I tend to, it's not a friction, but I tend to move my hand just a little bit. It's comforting and it's a little bit distracting. Feels a little bit more like a massage in through there. But right there is where I'm feeling it.
Same principle. I know I'm doing a good job if I see that ear moving.
So then I'm going to come up and get into the temporalis proper, right through here. Big hand again. I can use my forearm. Big hand. This is where the pressure is coming from. And I'm going to lean in. You'd be surprised the amount of pressure, as long as it's not pokey. You'd be surprised the amount of pressure that feels good in this area. So I'm going to kind of cup the whole temporalis. Good pressure. And then I'm going to say, okay, clench your teeth a little bit and then open. And I'm going to change my angle so that I'm compressing the area that is activating the most. And now we're actually doing the intervention. And I'll do that half a dozen times and I should feel less engagement of the muscle in the area.
Or that even I watch how smooth the motion is. Does it look easier for them to do?
You know, and then I'm just kind of working my way again to starting right in here, right at the top of where the ear joins, and down even to under the jawline in through here. And
the body uses any bony ridge or protuberance. I mean, those landmarks are anchor sites for muscle, deep fascia. So in general, you just can feel and follow wherever you feel like a bumpy ridge, that's where a focus can be found, or just around it, and you just search or are thorough and do a little bit everywhere. As you follow these ridge sites, you can just kind of trace these structures of the skull.
So my hand, okay, this big hand here, turning a little this way, a little that way, pushing down, pushing over to the side, very subtle. And then remember, you can use the ear to create a fascial drag in through here. So it gets real, one thing, real rhythmic. Here, here, open, close, good. Grab the ear over here, come on down, open, close. If I come across any spot that particularly feels familiar, let me know.
You actually want to say that?
Yep,
The temporalis had one,
did it.
right? A little bit more anterior. There, yeah.
All right, so he actually had a spot that was familiar. So try
Yeah, that's got a good referral. It's
Kind of
going actually back down into the neck.
squint your eyes. And then
Yeah, and that's it.
squint your eyes. I can feel it pop up a little bit in there.
That's very profound. When I have to really squint, but I do feel I'm having a small aha. I don't do this stuff a whole lot. I've been getting trapped for years working more like lower body stuff. So some of this is a good refresher for me.
Now see what happens when I bring that ear into
Yeah, that's
it.
a real.
And squint your eyes and clench your teeth. Now that's big. All right.
I wonder what that looks like.
So I'm working my way down, just working my way down. Now that masseter comes up behind the ear in here. You feel your jawline. So I want to get in there too. I'm getting that with just the side of my thumb. Just a little bit of a movement like that.
Move my jaw a little bit so I can see.
Right through there. All right. And then open, close. Now my focus is more down this way, not so much straight down. And then I'll curl my fingers right along the jawline. And open and close. And then kind of a, pizza dough, spreading pizza dough.
It's interesting when you reflect on this stuff. If you look at it from the, what we kind of teach you guys with is the traditional Western medical standpoint. But if you think about, some of the more traditional methods, like reflexology has a big foundation related to the ear. Meridian-based therapy have these meridian lines that follow these structures, and these practitioners have kind of used these very thorough process of working their way down and along these pathways. So if somebody were to watch her doing that, they could easily call it a meridian based like concept. But really it's that idea of thinking about the anatomy and all the potential movements. It's compression plus movement.
Because jaw has a translation. I could bring that in. Okay, and up and down with your jaw and then back and forth. And it also protracts and retracts.
Like any of this stuff, always better having a sense of humor. Hey, making them laugh is a good contract relax.
Did that help, Erica?
Yes, it did.
Now,
This is great stuff to try on yourself.
yes,
You can really do a good job on this. Scalp, I'm gonna look like a mess.
you
But-
do your other side
But yeah,
yourself.
just working my way through. And I've used a lot of this now. Some of this stuff for the neck. Oh, she's bought me like there's this looks like a plastic crowbar with 2 golf balls where I can pinch this stuff, or I've leaned into the back of a chair, grabbed a water bottle and done this. But for my palpation, using fingers first, but soft fist. Sometimes I'll get my elbow against the wall or something so that I can kind of lean into it. But using that soft fist, I can get just under my ear and I can feel that sternocleidomastoid, and I play with the movements where it gets more profound. So like she said, tucking the chin in and a little rotation. I really feel that kick on. And it feels good. Then my pressure here, I'm kind of pulling down and away from the ear. And I can feel the jawline. And I start, so I can feel my earlobe and I can feel my jawline, and I can feel that mastoid process. And doing this on myself gives me a really good perspective of figuring out if I can feel it on myself, I can find it on a client. And then being able to reflect what they should be feeling based on what I felt. If I can recreate that trigger point sensation for myself, then I can then reflect, it should feel like, I can say to the client, it should feel like this. And then I would just work my way further back. Harder to get pressure more back here.
You gotta lay on a water bottle. or
Yeah.
something.
But that sternocleidomastoid one, this really has been helpful for me. I get a lot of stuff up through here. Then tracing it, I showed you guys how to kind of come back down here and just grab anywhere, basically following the clavicle line. Start at the sternum, and you can work your way all the way out and play with some of these movements. And you can get, usually you can see, I can get a pretty good stretch of like that platysma and everything through here. Then one step further, any of the stuff, whether it be grabbing the ear, moving that around, doing movements with it. You know, I hadn't done that movement. I had forgotten this idea, but grabbing the ear and then doing that real squinty face, I really do feel it. That looked probably really silly, but
Find that spot.
yeah,
up there.
and that was going to be and that's the other part. So here on the temples, fingertips, I can feel the edge of this whole like temporalis goes in the nice circle. The fibers are kind of shaped like a shell, like a clam shell. So I can get more specific as I use my fingertips, but a big old palm, and I feel my palm kind of along this line of my ear, and I can feel this hard edge of the bone of the skull right here. And I just get kind of the pad of my thumb right there, let my whole hand fall onto the skull, and then I'm trying to pull that up and away from the ear. And you should see that you see that ear really moving. And then once I have that tension, then going in a circle.
And find your little spot.
And then I shift my orientation. So my fingers were kind of up at an angle that way. If I shift my angle, or my fingers are back and away, so now I'm along the edge of the skull, feel the edge of that ridge of the temporalis muscle here. If I now put tension here and work, always easier as I'm doing this, I usually would push against a wall to get that additional
Or
compression.
even if you
Lay down.
and we're leaning
Yeah.
against your.
Yeah, and that's actually usually what it is. I get like the armrest of a couch with a chair. We'll do that. So simple little self-care things, and then taking that all the way into the masseter. Find the bony ridge, lower compression, moving the jaw. Make sure you said back and forth, forward and back, up and down. People that have chronic head ache related stuff, and something, some stuff is going to always be hard for us
prove and objectify with, because everybody's body adapts very uniquely to, oh, how some people have a higher pain tolerance. Some people have just their personality is one where they're just more resilient. You know, they're just you got a tough persona, and they're just gonna not let being uncomfortable stop them from doing anything. So they're more pugnacious and resilient like that, right?
Pugnacious.
I guess that's not quite right.
Is pugnacious a word?
Yes, it is. but the way I tend to try to process this stuff is I reflect on that if somebody's uncomfortable, if somebody is having pain, it doesn't just change sometimes our posture, it can change how we even hold our face. You know, it's not dissimilar to like somebody that wears glasses. I have to wear glasses when I do a lot of computer work because I would get eye strain, and the eye strain would recreate more of this neck related discomfort. But to me, the idea of when you are stressed and or in pain, there's going to be kind of a facial skull muscle related effect based on, like, it's not just your posture being affected, it can literally be your facial expression kind of changes. You know, you can't feel pain without going into a frowny, you know, and nobody wants to be stuck in a frown. That's not fun. But the principle being, there's actually more muscles that can make you frown than they help you smile. So that whole like kind of idea that you have certain muscles, like even antagonists, you know, you have more flexors than you do extensors. You have more adductors than you have abductors. So strangely enough, are challenging even this in thinking in relation to how the jaw is set and playing with like lots of different movements, you'd be surprised that it can have a very profound effect without it being too hyper specific. And I sometimes go as far as thinking I need to help them not frown so much. I need to inhibit the frowning muscles.
You can use positional release too. No, I'm good right here. You can use positional release as part of the massage in this, especially when you're thinking TMJ. So you find the spot. Is that it?
A little bit further in, more anterior. You can even have them grab you and help find it. Now, this is a key point, by the way. TMJ, masseter is involved, but I search in the temples first.
Yeah.
Look in temporalis first.
All right, is that a spot?
Yes.
Okay, I want you to lean against my hand a little bit so that he's stable now.
So I'm pushing that way.
Creating the pressure. Now, I want you to move your jaw slowly in a few directions and see if you can get a spot where that lessens.
Right there.
And then kind of move your jaw all over the place. So that makes it a little worse.
Right this way.
Yeah, and then take it back to ease again. Oh, better.
Yeah.
So a person can do that themselves.
Yes.
Get right in where it's particularly tender. You can teach them.
Yep. Oh,
Okay.
what's that?
You can get right to the spot. And then teach them to find the ease.
The general principle is make it hurt less, make it hurt more. And they can do that with lots of self-care components. But even for us as practitioners, I'll have a conversation with clients, I'll say, you know, here's my goal with the muscle nudge technique. I want it to feel like what I'm pushing on, you're activating. And then you're letting it go and you're activating whatever, and then you're lengthening it. So whatever I'm pushing on, I want you to shorten it and activate it. And I want you to relax, and I want you to find a way to feel like you're stretching and lengthening it. They can innately, once they understand that basic goal, it feels correct to do. Like, okay, I push against you.
it feels innately right, and then stretching it and lengthening it. But letting their body guide you and guide them is usually much better than trying to be so hyper specific and saying, okay, you move just like this, because you might actually see them do a movement, or they might find a way to challenge their own body and or shift in such a way that they can get that lengthening better than me trying to be too hyper specific. The other one with the position of release element is it's really easy and much more comfortable. If there's a real hurty spot, just saying to a person generally, I don't know, I don't care what you have to move, use your whole body, find a position, use your jaw, use your head, use your arms, use your feet, I don't care. Find a spot where it hurts less. I'm going to hold this spot and you position yourself in such a way where it makes it feel better. And then we stay there for a while. And it's just for the sake of the massage, it gives them a level of control. But I mean, I don't want to just make them suffer for the sake of suffer, right? But there's a lot, there can be some really cool things as you watch how their whole body, how they can shift their whole body in relation to making the sensation less. That usually is an exaggeration of some distortion. If they've compensated in response to something, usually the position of ease that makes things feel better is an exaggeration of their compensation pattern that goes and then you just say, okay, now move out of that. Go in the opposite direction. Go somewhere where it feels like maybe it makes it a little bit more intense. Maybe it makes it feel like it's stretching, but keeping it pretty broad and ambiguous. Let their body kind of guide you and guide them. And it's doesn't have to be so hyper specific. It turns into compression. All right, client, make it hurt less. Use your whole body. Move everything. Use your eyes. Find a position with your eyes. Find a position with your neck. Even if I have to guide them through their body movements, look away, look toward it. Which one feels better? Okay, hold that. Move your head this way, that way. Find a place that's better. Move your shoulders. Which one's better? And just keep going down. And then moving out of that. And usually whatever movement they did, going in the opposite direction becomes the way that they go after the fact. And as I've seen, and she's helped me with, like, I've had some nerve entrapment stuff, and it was like real bad. I could barely move and it would go into spasm. And she used the eye movement thing where it was just enough compression and it didn't feel safe. It didn't feel safe to have somebody work in that area too much, because nerve pain, anybody that's felt it, can be very scary. But just enough to compress, and then just using the eye movement, look toward the spot, look away from the spot. And the person doesn't have to always do it right. They just but it was profound for me, because in that moment of it being very sensitive and very painful, it was a pretty profound effect. It worked really good. And when somebody's in a lot of pain, even 10-20% relief can be a lot. That can be super profound. That can be the difference of them getting a good night's sleep and not.
The only thing you have to do is just keep them moving slow.
And that's, yeah.
Yeah.
So
Move slow.
Controlled movements. People will just give you an all or nothing kind of deal. So I usually start with that as part of the conversation. When I tell you to do these movements, try to be real slow and controlled and precise. We don't need a big contraction or action. We just want there to be enough movement to feel like the muscles turning on, turning off. But the slower and more controlled, the better. And it's safer. So.
Okay, now, thank you, Erica, for, jumping up on that. Anybody else have anything that they would like for some clarity? What'd you think of this, Joanne?
Okay, I have a couple of things. I've been taking notes, and fortunate I can just go to my bookcase and pick up a book. One thing is that's very interesting is I have a client who I was massaging her ears for her TMJ and doing just as you demonstrated. And she came back after about the third appointment. She says, Joanne, you have to stop massaging my ears. They're getting bigger. So, because that's what she thought, I had to, I'm like, oh my. So, but I have a couple other things to mention. I had a client who came to the house, this is just recent, and unfortunately, I'm not going to see her, is she had costochondritis. Now that's inflammatory of the intercostal tissue. And she runs every day, she swims every day. She's 68 or 69, somewhere. No, she's probably 70, whatever. But very well fit, but she couldn't breathe. She said at night she couldn't breathe, so she had trouble. So she came to my house and I did the one where you have them breathe in and hold and pull down on the ribs.
Mm-hmm.
And then you have them breathe out and you press them back up into the diaphragmatic area. Press up and you do this just a few times. The following day, she said, it's a miracle. She says, I could breathe, I could sleep. And now, of course, I'm not seeing her because I was exposed, which I'm negative. I had a test taken and I'm negative, so I'm good. But that was somewhat of what you were displaying there about the rib movement, is you enhance that which is weak and you decompress that which is too strong. So enhance what's weak, depress what's too strong, and it will affect that intercostal area. Okay, and then the other thing where I, as listening to you, as breathing being a movement, yes, that's very true. The biggest thing I have seen in the short time that I've been doing massages in the last 2 months is breathing is affected strongly by their emotions. I have nurses that come in that are fearful, they're not living with their families, they're stressed, they're sad, they're tired, they're angry, people don't wear masks, they're just overwhelmed, and their breathing is very short. So I say nothing, I just observe, and I decide, okay. So the massage, I put an extra emphasis to improve their breathing, and they do have a better result with that. And a male client came in and he was very, very sad because he couldn't be with his mother who was in a nursing home who passed, and he just couldn't get beyond that stage. Again, his breathing was not shallow, but it was long, drawn out breaths, long. So I had to stimulate some of that breathing, not bring it down. Whereas with the nurses, it was bring it down. But with all of this, the biggest thing you have to do at this point, the way I see it, and I found out, is what's most important is a compassionate touch. You can use these techniques, but most of all, have a compassionate touch. And when my mother had COVID, which she's living and doing well, she came through it, she's 92. They gave her a nurse 24/7 for 3.5 weeks. And I'm a firm believer that because she had that compassion and they would hold her hand, they would talk to her. She couldn't see family. She had one day of just weeping and crying, thinking that they took all of her children away from her. And instead, they had a nurse holding her hand, giving her the compassion, caring for her, helping her with her oxygen, rubbing her arms, her feet. That, I believe, was 85% of her healing power, was to have that connection. And so a compassionate touch is very, very important for me to give. And living by myself, being by myself for a long time, that would be heaven. To just have that compassionate touch, you know. You unless you're around family. I mean, I'd hug a telephone post, you know.
Aw.
I have gone out and hug a tree. It's just having that embracing moment. And people are missing this. They are lonely. they inside, they're weeping, and that affects their breathing. So anyway, that's a big thing. There's just a couple of things I want to add, and then I'll be quiet, Sandy, I promise. The other thing is I did change my sleep pattern. I used to, for all my life, as a child, I was a short sleeper. So I slept like 4 hours a night, maybe. And my father would get on me and he would say, okay, you get up that early, you go sit outside. Don't be in the house, you disturb me. So I did that for years, watch the sunrise. Well, with this COVID thing, mark it on your book or your calendar. I'm sleeping 8 hours a night. And I wondered, what's happened? Why am I doing this? I don't know. Probably because I didn't get that hug that night. Oh, well, whatever. But one other thing is to let people process, give them that compassionate touch. Don't interfere with their thoughts. Let them get through it. Allow them their space. And normal is just a setting on the dryer. Each day we can embrace what is presented to us. It's a new life, a new day. And you can embrace whatever comes before you. I think that's the greatest thing. So that's how I feel about the word normal. And Maya Angelou, I love her. She said, every storm runs out of rain. So hang in there, keep your umbrellas up, and splash in the puddles. Love and embrace whatever you have for the day. Just whatever it brings, embrace. And that's what keeps you well. You know, just, so what? The roof fell down a little bit. Oh, well, fix it. You know, just embrace the day. Compassion and love for all mankind.
Boy, Joanne, I could have used you during my divorce. I mean, I needed to live with you.
The whole point is, I did divorce. We won't go there, okay? But you know what? Whatever you're going through, it's in the past. Let it go. Don't take that guilt trip. Do not take the guilt trip. Let it go. You can't go back. Just like
No.
C.S. Lewis. Yes, that's who it was. He said, you can't go backward and change the beginning, but you can start where you are and change the ending. So each morning, it's a new start.
Thank goodness.
Awesome. Yeah.
Yeah. Yeah. So however long this may go on, you know, it's okay. It's okay. Let's weather the storm and let's do it well. And let's do it with respect and love for mankind.
Well, and you know, it's putting us in a place where we have to adapt, like this particular class.
Right. Right.
So that's a great way to end this segment. And the only last thing I need then is for you characters to tell me what you want to do about tomorrow. Do we want a class tomorrow or not?
Well, I'm not able to come.
Okay.
So-
Same. I think a Zoom would be better.
So, well, we wouldn't be in the classroom for sure. It's whether or not we have a Zoom tomorrow.
Okay.
Yeah.
I'll be home, but I couldn't come to the enrichment center.
No,
Okay.
no hands-on classes yet. Well, take a look in January and see if we can. But
Okay.
so hands up if you want a class tomorrow, or hands up for a class tomorrow. Okay, so I will put a link up on Canvas. I'll send you the link. It'll be at 9 o'clock, and whoever's there is there. How's
Okay.
that?
Okay.
All right, everybody. We will hopefully this recorded.
It was great.
We're good.
All right, everybody. Talk to you tomorrow.
Bye.
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 Great day.